This is now the case of a patient with ischemic cardiomyopathy implanted with a dual-chamber ICD and hospitalized for syncope and shock. You can see that this is a ventricular tachycardia, and then a first burst is delivered, second, third, then a ramp, a second and a third ramp. They are all inefficient, and the next therapy is a maximal output, a shock in the VT zone, and you can see that there is a return to the sinus rhythm. As explained before, the choice of the amplitude of the first shock in the VT zone after sequences of ATP is debatable. The advantages of programming a maximal output shock, like in this example, as the first shock delivered in the VT zone, are first, to increase the likelihood of VT termination at first attempt and to minimize the number of shocks delivered. The second advantage is with a maximal output shock, you increase the probability to be above the upper limit of vulnerability in the atrials and in the ventricles, and therefore you decrease the risk of transforming an organized VT to a potentially lethal VF, like in the previous example, or you also decrease the risk to induce atrial fibrillation. The third point is that with programming high amplitude shock, you increase the likelihood of converting atrial fibrillation should the shock be inappropriate. The question of the pain and discomfort associated with the amplitudes of the first shock in the VT zone is really complex. It has been suggested that the first shock in the VT zone could be arbitrarily programmed at a lower strength to terminate the tachycardia while limiting the pain it causes. However, it is clear that a second shock during the same episode is always much more painful than the first one, and therefore the priority of programming may be to increase at maximum the capacity of reducing the arrhythmia in a first attempt.